Now I request Dr. Samyukta Sadasivan, Assistant Professor, Government Medical College, Thrissur, to talk about her perspective of CVI, that is an ophthalmologist. Thank you.
Good morning, everyone. From where Madam has stopped, I'll be continuing with a small presentation on the ophthalmologist perspective of CVI. So what is the primary role of the ophthalmologist? To establish a diagnosis of CVI after a comprehensive eye examination compounded with effective counseling, which sets ground for further management. So how do you diagnose CVI? When the visual performance of the child does not match with the ocular findings, especially when there is a history of a neurological ailment or there is an eventful perinatal period. Think of CVI when the parents complain of variability in visual performance. They say that the child sees at times, sees better at times and not at other times. They also say that the child is not able to establish any eye contact. There is a limited or a fleeting visual attention, that they use more of proprioceptive sensations to do tasks. They take more time to learn details of an object, that they have problems with eye-hand coordination, difficulty in recognizing people by seeing, or difficulty in understanding language of facial expressions, or in judging depth and distance. Always think about coexisting OVI also, ocular visual impairment, because congenital cataract and optic atrophy are frequent associations. Optic atrophy has been found to be associated in nearly 40% of cases. And there it is important to identify the cause for the optic atrophy also. So comprehensive eye examination follows. And examination, while we do an examination, we should think about two aspects. We have to check the visual function as well as functional vision. Both are different. So when we assess the visual function, you should, your routine examination protocol, like checking for acuity, contrast sensitivity, color vision, peripheral vision, and extraocular motility pattern, all these fall under testing for visual function. Now, functional vision assessment aims to ascertain the limitations of binocular vision in everyday life. So this is a very useful analogy they've made. The measurement of visual function is like measuring the feet, while the assessment of functional vision is like fitting shoes. So this is an entire list of behavioral patterns which we observe and make use of in understanding functional vision. So as is routine, we should document the head posture, if any, adopted by the child. As Madam listed, so many head postures are taken up by the children depending upon their disability. Congenital motor nystagmus, poor neck control, spasticity, all these things make the child adopt specific postures. Document them. Facial asymmetry is possible because of the underlying genetic or metabolic cause which is attributing for the CVI. And different ocular alignment patterns are noted. Note these. Vision assessment, you have to go for qualitative tests as well as quantitative tests. You can document these, whether the child is able to do a central steady maintained fixation, see if he is able to fix and follow objects, or if there is any resistance to occlusion. Quantitative tests, we have Lea grating, stellar acuity cards, Cardiff acuity cards, Lea symbols or Lea cards for testing near vision. These are the different methods of testing visual acuity, age-appropriate methods, modified after Hyvarinen in 2000. And remember, when you check visual acuity in children with CVI, higher contrast and background illumination may be needed to obtain reliable responses. Contrast sensitivity, we have Hayden-Hardy low contrast tests, and visual fields, gross peripheral field can be tested by using objects of interest, like a familiar toy, illuminated or bright, which are brought suddenly in the periphery. This is Atkinson's et al.'s test battery for the assessment of functional vision and oculomotor functions. So many additional tests are also described. And we shall make it a routine to do a thorough anterior and posterior segment examination. ROP has been found to be coexisting with peripheral PVL, and pseudoglaucomatous optic disc with narrow NRR is noted in children with PVL occurring after 28 weeks. Refraction gives special stress. You have to do dynamic as well as cycloplegic refraction. 10 to 60% of children with CVI have significant refractive errors requiring spectacle correction. Suma Ganesh et al., they have done this particular study where they found that simple myopic astigmatism is the most frequent refractive error in children with CVI. And 57% of children with varying types and severity of cerebral palsy and 80% of children with Down syndrome have been found to have reduced ability to accommodate. How do we assess accommodation? We shall observe the pupil size while we do a dry retinoscopy. As the child switches attention from a distant to the near target, if it doesn't become small, if the pupil size doesn't become small, think of impaired accommodation. And if the retinoscopy reflects changes from width to against and the pupil becomes small, it indicates that the child can accommodate. Sometimes these children won't be able to cooperate for retinoscopy. You can have ready-made glasses of +3, +4, +5 diopter lenses, and then you can make them wear the glasses and look for the behavioral pattern. And both eyes converging on a near object again indicates that possibly the child is accommodating. Imaging has a definite role. These are the different category of pattern of lesions which we can expect in imaging. So the successful intervention known is spectacles in correcting the refractive errors and accommodation related problems. So, this is something which requires mention. When you go for visual stimulation exercises in infants with CVI, make use of large, high contrast, lighted, reflective, moving objects in an uncluttered environment from different directions with variable level of light in the environment, and avoid overstimulation, and avoid these when the child is hungry, tired or frustrated. Special considerations while giving glasses: take into account the lack of accommodation, give the required add. And one more point is that appropriate spectacle frame adjusting to the shape of the skull should be chosen, because these kids would be using other aids like hearing aids also. So there should be space for accommodating those as well. And plastic lenses are safer, weightless, more comfortable. These are the issues related to the usage of glasses. And counseling is of utmost importance in these children. Always focus on the strengths of the children and empower the parents to modify the visual environment. We should give them necessary assistance in finding experts to control the systemic issues. And this is another thing which requires attention. Reports on the outcome of visual and cognitive functions should be sent to the pediatric neurologist and psychologist, and definitely to the teachers also. The parents and teachers should understand the outcome of such assessments to support a child with CVI. So it's basically a multidisciplinary approach, and it definitely works. Thank you.